Good morning, everybody. We are ready to start the second day's session of yatharthcon 2024, Focus and Regional Anesthesia. It's going to be a wonderful, educative session today. We have live transmission from the OT, along with masterclass on scanning in the auditorium. I'd request you all to kindly settle down. We are on a tight schedule and I've been asked to make sure that we keep time as per the schedule. To begin with, I have with me Dr. Day-2. And we are going to start with the ultrasound scanning of the upper limb. Over to sir.
Good morning, ladies and gentlemen. On behalf of Dr. Anshuman, Yatharth Hospital, I welcome you towards the live demonstration as well as master scanning. The way we have planned is, the moment operating room is ready with the cases, we'll stop master scanning, and in between two cases, we'll again continue with the master scanning. So there will be some interruptions in the master scanning, but in next 4 hours, we hope to cover as much as possible. So all those who are standing on the last row, please request to take your seats and put your mobiles on vibrating mode so that we have least disturbance. And it's going to be an interactive session where you are free to ask us any number of questions. We'll try our level best to answer them then and there, but in case we are not able to answer, we'll take them subsequently during lunchtime or panel discussions or tomorrow. Okay? So,
as it's a master class, definitely the faculty is the top class, and it's my request to all those who are non-delegates to kindly leave the hall because there is a lot of noise, and I think we will be missing on many important teachings which they will be doing. So this will be a mix from OT and demonstration live on the volunteer, and whenever we are ready with the patient in operation theatre, we will go for the live block to the operation theatre, right? So this program is designed like that. May I request Dr. Day-2 to now begin with this session of live scanning?
Okay. So first and foremost, we are going to do a master scanning of the upper limb above the clavicle. So in order to perform above clavicle blocks, there are two set of blocks, the interscalene and the supraclavicular brachial plexus block. The scanning sequence, irrespective of the fact whether I am doing a supraclavicular or interscalene or scut block or superior trunk, these terminologies will be made clear to you while I scan would be the same. Thereby meaning the position of the volunteer or the patient is going to be supine. The head will be turned towards the opposite side. The limb, the upper limb, try to make it as close to the body as possible, and in case if it's possible, you can place a 500 ml RL or NS bag in between the two scapula so as to make the space more prominent. That we haven't done as of now. So can it be done in any other position? The answer is big yes. We can do it in a semi-recumbent position as well as lateral position also. For example, in case you are doing shoulder arthroscopies in lateral decubitus position, the blocks can be performed after general anesthesia induction and the position has been given. And once you try in lateral decubitus, you would realize that giving a block is much easier as compared to supine or a semi-recumbent. So since it's a superficial block, we'll be using a linear transducer. So the way we have to remember is, for performing regional anesthesia, along the line of visual axis is what is required. What I mean is, the relationship between my visual, that means my eyes, the probe, the patient and the machine should be in one line. Is my ergonomics correct for this demonstration? The answer is big no. Okay, but in case you have to perform the block, this should be the ergonomics. I'll be focusing here because the ergonomics is not correct. So I'll be using a linear transducer. The frequency is between 3 to 12 hertz. This is a Mercedes-Benz ST from Sonosite. So Sonosite has various models. This is the latest edition, and you will realize the difference as compared to the previous models. So where do I place my probe? I feel for clavicle, and the first and the foremost is I place my probe just superior to the clavicle. The aspect marker, the left hand of the screen, my dear friends, is medial. Okay? That means this half is lateral, this half is anterior, this is posterior. Can we decrease the depth?
Feel free to ask the questions. Just raise your hand and then you can ask the question. Don't interrupt it, right?
Okay, so what is this pulsatile structure which you visualize? Anyone? Let's make it interactive. It can be one way. Subclavian artery. Can you see some kind of neural elements? Okay. So, can you identify what is this structure? Do you call it first rib? Is this one or this one? Okay. So, how do we distinguish? I call it this as first rib, this as pleura. Difference समझ आ रहा है आपको? ये first rib क्यों है? There is a white hyperechoic line with an acoustic dropout. This is the Shimbri pleura. Right now my subclavian is resting on the pleura. Now your doubts are clear or you are still doubtful? Now my subclavian artery, ये आपका pointer नहीं काम कर रहा दोस्त, is resting on rib. Right now it's resting on. Are you convinced or not convinced? So what is this? This is the bunch of grapes. Now the next step is I'll keep sweeping my probe cranially and identify the vertebral osseous anatomy and the diving of the respective neural elements towards their intervertebral foramen, and then during the caudal sweep they would come out, and then we would be able to decipher what this bunch of grapes is. Can you reduce the depth a little more? Okay. So as I tend to sweep a little cranial, my dear friends, keep in mind what is happening. Okay? Then ये और नहीं है आपके पास, ये ना बटन भी नहीं प्रेस हो रहा. So what is this muscle? On the medial side, anterior scalene, middle scalene. Now the neural elements were situated like this. Now they are getting condensed between anterior scalene and the middle scalene. Okay? Can you identify for yourself? They are getting condensed. So now we have to identify these neural elements where they dive. Can you identify this osseous structure? What is this? Anyone? This represents the vertebral body of the C7. This is the posterior tubercle. Anterior tubercle for C7 is absent or rudimentary. This first thing you have to realize, that as I sweep upwards you would see the C7 vertebral body. Okay? Next, what would I see? C7 के ऊपर क्या आता है? एक और आया anterior tubercle, posterior tubercle. Anterior tubercle, now you realize, is larger than the posterior tubercle. So where have I reached? C6. Again I will go back, my dear friends, again starting, so that you get a, I am at supraclavicular brachial plexus fossa. Okay, coming up, a little up, little up. Can you see the C7? The neural element diving towards that intervertebral foramen is C7. Till this time, any doubts, any questions? Now tomorrow, will you be able to identify C7 vertebral body with its posterior tubercle and the neural element diving towards the intervertebral foramen? Okay. So as I continue to sweep upwards, okay, I get a prominent anterior tubercle, a less prominent posterior tubercle, and this is the neural element which is diving. This is C6. Okay. Next coming is the C5. Can you see C5? Now you realize the anterior tubercle and posterior tubercle for C5 are almost equal. So this has been described in literature as a camel hump, fish mouth appearance. So a normal individual, what will he do if he has to give scalene brachial plexus without realizing what are these neural elements? Will deposit the drug here. But as a student of RA, we should know which neural element we are blocking. So this technique is known as sequential ultrasound imaging technique for identification of individual neural elements of the brachial plexus. So now you have a fair idea that C7 will not have any anterior tubercle, C6 will have a prominent anterior tubercle, and C5, the anterior and the posterior, would be almost equal in size. So again, I'll start the cranial sweep from the supraclavicular fossa. Again, observe. Fine. As I keep moving upward, can you identify C7? C7, okay. Next to dive is C6. Next to dive is C5. Now caudal sweep. C5 is, can you decrease the depth one more? Okay. C5 is coming out. The moment it comes out, can you realize it's split into two? So C5, my dear friends, will be bifid in almost 95 to 100% of the cases. Previously, what we were taught when I started 2008, it was said all the neural elements C5 to T1 are visible in the interscalene groove. Now we know the traffic light signal is formed by C5 and the split C6. Okay? Again, observe. Can I have a little more jelly? इसका ना पिलो हटा दो थोड़ा सा ना निकल जाएगा. Okay. Thank you. Okay, this is C5. Okay, the moment it comes out, can you see it splits? Okay, yes or no? Yes, sir. Very nice. Next, what is the next element you feel will be coming out? C6. Okay, now एक depth reduce करो. One more. Okay, now you realize C5 again going up, C5, C6, they are fusing. Can you realize this fusion? Yes or no? So this is the formation of the superior trunk. These days what we advocate is, instead of giving a classical interscalene level block, which is at a much higher level, which is almost at this level, give a block where it fuses. This is the superior trunk, C7 is underneath. So for shoulder, a superior trunk plus a supraclavicular nerve, which is a branch of cervical plexus, is sufficient. Is that okay? This block has been described by Dr. Shiva Shanmugam, who will be doing a live demonstration, as a SCUT block. Okay, we use it for shoulder surgeries. So once again, I'll start from, again, starting point, home page is always supraclavicular fossa. When in doubt, subclavian artery, the bunch of grapes. Okay. So the traffic light signal, is it clear to everyone, or any doubts? Again I am going up. Now C5 हो गया, start है. So the fusion has happened. This is C7. आपको pointer का करना पड़ेगा बॉस. ठीक है. एक सेकेंड, लेट मी गेट माई पॉइंटर. नहीं, मेरे पास है ग्रीन, नहीं एलईडी स्क्रीन पे. आई हैव गॉट इट, आई विल यूज इट. थैंक यू. अभी टाइम है ना? Subclavian, again going up, up. Now, a person who's beginner in this field would think that this is the plexus in the interscalene, anterior would like to deposit here. But as a student, you would realize that this fusion is much more important to analyze. This is the C7, which is bifid, and now C5 and C6 will split into SPA as I come close to the supraclavicular brachial plexus. Okay, okay. So a little difficult to analyze. अब आपका SPA बन गया, SPA. What is SPA? Can we have some light so that I can see them? I am not able to sleep. Anybody, what is SPA arrangement? Okay, the superior trunk is formed by which all neural elements? C5, C6. Middle trunk is formed by 7. Inferior trunk is formed by C8, T1. C5, C6, superior trunk formation you saw. As it goes downwards towards supraclavicular fossa, it splits into 3 divisions from lateral to medial, which is known as a SPA arrangement. S stands for supraclavicular nerve, P stands for posterior division, A stands for anterior division. Because of good knowledge of the anatomy and good resolution of ultrasound machines, we are able to analyze these neural elements. अब आप क्लासिकली कोई आप में से ब्रेकियल प्लेक्सिस करेगा, वो कहेगा ये तो है, मुझे क्या जरूरत है इसमें, सुपीरियर ट्रंक कौन सा है, मिडिल ट्रंक कौन सा है. Is it okay? But we should be able to decipher it, and we are deciphering it. Okay. Once again, in a caudal sweep, again try to visualize the fusion of C5, C6. थोड़ा डेप्थ बढ़ा दो. Okay. C5, C6 fusing. Okay. Keep a watch on this. This will split into 3. अब डेप्थ कम करते चले जाओ आप. और कम कर दो. एक और कम करो. एक और कम करो. Okay. Now you see for yourself. This is getting split into 3. SPA. Right block 2018. Okay. This was meant to target the anterior cutaneous branches as well as the lateral cutaneous branches of intercostal nerves. So as you know by anatomical knowledge, the anterior cutaneous branches would cover the strict midline till the mid-clavicular line. From mid-clavicular line till approximately posterior axillary line, they are covered by the anterior divisions of the lateral cutaneous branches. So the classical subcostal tap, it was said that it will cover both the branches. But over the period of time in volunteer studies, in clinical studies, we have found it only covers anterior cutaneous branches more than the lateral. So what about my subcostal incisions? What is happening in open cholecystectomy, radical cholecystectomy, Whipple's? So what they have said, the external oblique intercostal facial plane block will provide good analgesia, only somatic. There will be no visceral component. Even in TAP, please understand there is no visceral component. Only a quadratus lumborum block can give you some kind of visceral analgesia in addition to somatic. So we choose the plane between 6th to 7th intercostal spaces. Needle classically has been described to coming from cranial to caudal, depending on your preference. And from mid-clavicular line to anterior axillary line, the probe is obliquely kept. Is it okay? For Whipple's, we place a bilateral block because the incision extends to, depending on the level incision extends to, and we can place catheters in this place very easily. So is the concept of rectus sheath and external oblique clear to you guys? Any questions from your side? Okay. So I again start with my above the clavicle limb master scanning. So any questions on above the clavicle? I'll do a quick recap. Anything? If there are no questions, there are two things. You have understood each and everything properly, or everything is going above your head. So you can ask me 10 times, I won't hesitate explaining you 20, 50 times, but I want this concept gets clear in your head that how to identify individual neural elements. We'll do it. I'm doing it again because I don't want you to carry the take-home message which you must be doing interscalene supraclavicular. Effect भी आ रहे होंगे हमें वो उस पे outcome is good, but we should have a knowledge where we are actually depositing the drug, where our needle is, so as to give good results and to decrease the complications. Okay. So again, subclavian, this is the entire. Okay. So your needle will come from this place, will go towards first injection. Where do we give in supraclavicular brachial plexus? At the corner pocket. What is corner pocket? Anybody? The space between the first strip and the subclavian artery. This place houses the inferior trunk. Okay. As I go upwards, again try to identify the neural elements. So what is this? C7 now is clear. C6 आ गया. C6 निकलते ही बाहर देखो दो में स्प्लिट हुआ कि नहीं हुआ, जैसे C5 में हुआ था. Okay. So C5 C6. Now they will fuse. Can you see the fusion? Can you appreciate this fusion? Now can you please decrease the depth for me? One more. One more. One more. Now please visualize the split. देखो suprascapular nerve split होती जा रही है. Can you appreciate? Can you appreciate? Keep an eye on this only. बाकी मैं P, D आपको सब दिखाता हूँ. Is it okay? Coming back again, P and A. So this power arrangement is what we call it the superior trunk at the distal level. Can you increase the depth? S, P, A. Clearly visible है कि नहीं आपको? पहले जब मैंने यहाँ प्रोब रखा था किसी को समझ आ रहा था? अब समझ आ रहा है? अब कल से हम अपनी प्रैक्टिस में शुरू करेंगे कि नहीं करेंगे? करेंगे. SPA. What is this? This is the middle trunk. C7. अब the next question comes, what about inferior trunk? Inferior trunk is formed by the fusion of T1. But over the period of time we have realized to identify T1 it's only possible in 34 to 35% of the cases. I'll try my level best whether it's possible or not. How does it come? It comes like a U-turn sign. Okay? From the pleura it will come and rise like this. Watch my hands, don't watch there. It will come like this and rest on the first strip and fuse with the C8. I'll try my level best whether I can do it. For that I have to tilt my probe, ek depth bada do, towards the thorax. Now I'm tilting my probe towards the thorax, trying to visualize whether I can identify. Yes, I am able to identify. Very nice. So again, what is this structure? Subclavian. What is this? Rib. What is this? Pleura. Try to watch this. This structure will come like this and fuse, go like this. अब देखना आप. हुआ कुछ? हुआ? Can you identify? Convinced हो तो हाँ बोलो, नहीं हो तो okay. See, my hand is going now towards pointing proper into the thorax. First I was perpendicular like this. ये देखो. आप कैमरा यहाँ से हटा लो. आप किधर लाओगे? See, आप पहले मेरा ना यहाँ कैमरा पे फोकस करो. Let them. ये दिखाओ मुझे. ये दिखाओ. Sir, right now it's perfect. आप उस तरफ मत देखो please. आप इस तरफ देखो. This is perfect perpendicular. So in order to visualize the T1 coming like this as a U-turn. U-turn हम लेते हैं. U-turn में क्या है? ऐसे करके U आ रहा है. It will come from the pleural surface and then rise up on the first strip. Because it has to fuse with C8 to form the inferior trunk. Now what will I do is, मेरा हाथ clearly visible है. मैं धीरे धीरे अपना probe I'll be tilting into the thorax. Can you identify this moment? So this I'll be doing and you will see the change. Now perfect perpendicular. Okay? ये देखो ये region. अब ultrasound screen पे focus कीजिए. ठीक है? अब मैं tilt कर रहा हूँ, tilt कर रहा हूँ, tilt कर रहा हूँ. ये देखिए. Can you see something happening? It's not that clear, but you can understand that some neural element will come like this and fuse like this. So this is the formation of inferior trunk, and that is why we recommend that first injection should be at the level of corner pocket to take care of the inferior trunk. If you miss out on the inferior trunk, your ulnar territory is going to be missed out. Now the bunch of grapes is getting much clearer. ये हमारा spa arrangement आ गया, ये middle trunk आ गया, ये हमारा inferior trunk आ गया. Is it clear or not? Initially I had kept my probe 10 minutes back or 15 minutes back. क्या लग रहा था हमें? Entirely bunch of grapes लग रहा था. अब now the bunch of grapes has got individual identity. The identity is the upper trunk, ठीक है? The middle trunk and the lower trunk. If I tilt, you can see the fusion happening here. Okay? Another important aspect which I wish to tell you, in this position, giving a please focus on my hand like this. Giving a block would be quite difficult because it's tilted inside. So what you can do is, you can keep your medial edge fixed. This is fixed. I'll keep moving my lateral edge a little cranial. A little cranial. Okay? And now you see the plexus becomes a little better. I go back to the original position. Okay? Now a plexus becomes little better. But your corner pocket now is exposed because now it is lying on the pleura. So at times you might require this maneuver, at times you might not require this maneuver. But keep it in mind, if you are finding it difficult, then keep your medial edge fixed. The lateral edge you can move a little cranial. Okay? Movement समझ आ रही है? ये fixed था, ये ऐसे कर रहे हैं. Is it clear? Fixed. So you can have a better. So is the spa arrangement clear? Superior trunk clear? So superior trunk we can perform at two places. Okay, I'll go once again on the top surface. Coming out, coming out, coming out. Okay, so this is the place where I would like to do the superior trunk. Can we decrease the depth? So can anybody identify phrenic nerve right now? Where does the phrenic nerve run? एक और डेप्थ कम कर दो, एक और कम करो अंकुश. Okay, okay. Where does phrenic nerve run? Middle scalene पे या anterior scalene पे? Madam is answering everything for you. You guys have to answer. So I'll tell you, the phrenic nerve is formed by the fusion of C3, 4, 5 with a principal contribution from C4. It's 0.76 millimeters in diameter. Okay, it runs on the surface of anterior scalene muscle. At the level of C5 it's virtually coincident with that. As I move 1 centimeter down the neck, it will move 3 millimeters away towards the medial side. Right now it is sitting very close to the C5. ये आपको दिख रहा है एक स्ट्रक्चर, ट्यूबुलर स्ट्रक्चर जो डॉक्टर मनीष पॉइंट आउट कर रहे हैं. एज आई कीप मूविंग डाउन, एज आई कीप मूविंग डाउन, डॉक्टर मनीष वहीं पर ही रखे हुए हैं, ये बिल्कुल एकदम मीडियल साइड में चला जाएगा. सो द phrenic nerve is situated very close. So that is why we advise to give your block at the level of superior trunk. तो थोड़ा सा डिस्टेंस उसका, अब देखो उसके अंदर मर्ज हो जाएगी ऑलमोस्ट, पता भी नहीं चल रहा, बिल्कुल C5 के बिल्कुल इसके अंदर आ गई है. सो phrenic nerve you will be able to identify in majority of the cases provided you try. There is a classical saying, if your mind doesn't know, you will not be able to see. So I have shown you phrenic nerve. What other nerves are important to you? There is two nerves which are situated in the substance of middle scalene. What are those two nerves? Dorsal scapular and long thoracic. So our needle is, अब depth बढ़ाते चले जाओ, 3 centimeters. So our needle is coming from lateral to medial direction. It is traversing the middle scalene. कर रहा है कि नहीं कर रहा? हाँ या ना तो बोल दो प्लीज. देते हो ना ब्लॉक्स? कर रहा है तो क्या इंजर हो सकता है? और डॉर्सल स्कैपुलर, कभी हमने सोचा है कि विल बी एबल टू आइडेंटिफाई? नाउ आई विल शो यू हाउ टू आइडेंटिफाई, एंड फ्रॉम योर tomorrow onwards in your practice try to identify. Even if you're not able to identify properly, I'll show you the approximate location, because in 100% of the cases you are not able to identify. They traverse through the space of the middle scalene and then travel. So for that you need a good anatomical knowledge. Again we go back from the starting home page, go back. Now can you see the superior trunk? Can you see these hyperechoic smudges? These could very well reflect the nerve. For me to say them 100%, I'll have to use a nerve stimulator. But you remember that आपको ये दिख रहा है white? Can you differentiate between this white and this white? This white looks a little different. This white represents the striations inside the muscle. This white represents something different. This could be the nerve because of anatomical knowledge, and I'll try to trace. Yes, this is the nerve, it's going towards its respective route. As I move towards the supraclavicular fossa, they will escape from the middle scalene muscle. देखिए ये जा रहे हैं, ये जा रहे हैं, ये यहाँ से निकल जाएंगे. So whenever you are giving the block, आप interscalene, आप में से कोई आएगा, आप interscalene जो करता है, किस level पे देते हैं? Let's do a small exercise. Anybody who gives interscalene? See, if we are learning from each other, come. आप किस लेवल पे देते हैं और हम किस लेवल पे आप रिकमेंड करेंगे, लेट्स पता चल जाएगा हमें, ठीक है? चलिए, इट्स ओके, सी वी आर हियर टू लर्न फ्रॉम ईच अदर. हाँ हाँ, आप कीजिए सर. आप किस लेवल पे देते हैं आप मुझे बताइए. आप यहाँ से देख लीजिए. हाँ, उसमें आपको क्लियर नहीं लग रहा. जहाँ, हाँ आप जहाँ कर रहे हो हम फ्रीज कर देंगे. आप इस लेवल जहाँ बताइए, इस लेवल पे देते हैं, फ्रीज कीजिए. चलिए, हाँ नहीं, आप अनफ्रीज करो जहाँ आप इमेज पे सेटिस्फैक्शन हो. देन विल हैव अ डिस्कशन, गुड डिस्कशन. चलो, ओके. सो सर गिव्स, आप बैठिए सर. थैंक यू. अभी अनफ्रीज मत करना. थैंक यू वेरी मच. So this is medial side. He likes to give where he sees the traffic light signal. Is the traffic light signal visible to everyone? What is this? C5, C6 and C7. So his needle comes from this place. अब ये क्या दो nerves हैं? Dorsal scapular and long thoracic. आप attention दे रहे थे, हो सकता है आपकी needle इनके side से निकल रहा हो. Now henceforth you will be more careful. So what we recommend is a shallow trajectory coming above these white hyperechoic smudges. I am still not with confidence I can say these are the nerves, but in my clinical experience this will turn out to be both the nerves provided we do a nerve stimulation. अब आपने GA induce किया है, will the nerve stimulation work? If you have given a neuromuscular blockade, it will not work. If you are doing on a spontaneous respiration, it will still work. So dorsal scapular supplies which nerves? Rhomboids. Long thoracic supplies which nerves? Serratus anterior. So which EMR, evoked motor response, you will. Okay, so we are ready and we'll still continue. Okay, if you have any questions related to master scanning, you can ask me. Chalo, abhi tum kar den. Accessory structures which are surrounded, which surround actually the plexus and where actually your needle can go. Can we have a recurrent laryngeal nerve palsy? Where it does travel? It travels between trachea and esophagus, which is quite medial. But injecting 30 to 40 mLs under blind, which we do not recommend. We recommend at least, if you do not have ultrasound, do under venous guidance. But try to have ultrasound as much as possible. Okay, can we have the jelly please? So once again, we start with the supraclavicular fossa, cranial sweep, identify all these nerves, the vessels. There are so many vessels. What about dorsal scapular artery and the suprascapular artery? कभी सुना है कि नहीं सुना? चलो, so I begin. Again we go up. The neural elements are stacked. Can you see a structure? Okay, I move towards the supraclavicular fossa. Keep following this hypoechoic structure. ये जा रहा है कि नहीं जा रहा है इस ग्रुप में? वापस आ रहा है कि नहीं आ रहा? ये वापस आ गया? आ रहा है कि नहीं आ रहा? नहीं कन्विंस्ड हो तो बताओ. नहीं कन्विंस्ड. डेप्थ रिड्यूस कर दो अंकुश, 2 सेंटीमीटर.
अंकुश डेप्थ रिड्यूस करके ना वहाँ के ब्राइटनेस कम कर देना जरा, क्योंकि स्क्रीन पे थोड़ा वाइट ज्यादा नजर आ रहा है.
देखो यहाँ पर परफेक्ट दिख रहा है. When we transmit to these LED screens, the pixels drop. So if anybody has doubt, you can come here. It is very visible here. It's like ये इस structure को follow करो.
Low.
A small hypoechoic. Hypoechoic means a black. This will happen to move like this. Okay. अभी यहाँ से शुरू हुआ, अब देखना move करेगा. Can you appreciate its movement?
Yes sir. Yes sir.
Dr. Manish तो कर सकते हैं. He has an eye for it. Unless and until the audience says, हो रहा है कि नहीं हो रहा? So this is phrenic nerve. Okay. So this much which I was talking was the dorsal scapular and the long thoracic. So एक depth बढ़ा हुआ अब. Can you see some flat structure? What is that? Rib है. ठीक है. ये क्या आ गया? C7 पे आ गए. एक कलर डालो इस एरिया में. थोड़ा सा मीडियल और चले जाओ. Can you see the pulsatile structure? What is this? Vertebral artery and vein. At the level of C7, they do not enter the foramen transverse area. 90% of the cases at the level of C6, they will enter inside. So if you are not mindful of your needle visibility, you can enter the vertebral artery and can lead to LASTs. This has been reported in literature. With ultrasound guidance, obviously incidence would be 0, but blind, it would be there. And if I move a little, up color hata do. एक depth बढ़ाना, एक और depth बढ़ा. At this, what is this muscle? This is longus colli. On top surface of it, the sympathetic ganglions are, we do that block. What is that block? Stellate ganglion. So I am not that far off. ये देखो यहाँ हम इंजेक्ट कर रहे हैं, ये हमारा साइट है, मेरी नीडल ब्लाइंड केसेस में वो यहाँ तक चली जाती थी. पॉसिबल है कि नहीं? अल्ट्रासाउंड गाइडेंस में नहीं है. So this is how I am trying to show you the complications you can land up. Is the sono anatomy above the clavicle clear to you? This was regarding brachial plexus. Now I'll come to the cervical plexus. In the era of ultrasound, we are decreasing the volumes like anything. Classical for interscalene used to be 20 mLs. When you give 20 mLs in interscalene, do we need to block the cervical plexus separate for the cutaneous analgesia of the shoulder? No, because the drug would ascend upward and block the C1, 2, 3, 4 from where the cervical plexus originates. But we are in the era of procedure specific, motor specific, opioid sparing, low volume blocks, even anesthetic low volume blocks. So once we give low volume, the drug will not ascend upwards. Thereby phrenic nerve will be, phrenic nerve will be okay, but cervical plexus will not be blocked. So what is the nerve which supplies the cape of the neck? The supraclavicular nerve, which is a branch of cervical plexus. So cervical plexus can be performed at 3 levels: superficial, above the level of sternocleidomastoid; intermediate, between the level of sternocleidomastoid and the prevertebral muscles, which are those scalene muscles I am talking about, between 2 facial layers, the investing layer and the prevertebral layer. Okay, and then there is a deep cervical plexus block. So the current literature recommends that deep cervical plexus block should not be performed. Please remember, should not be performed. Your intermediate cervical plexus block, which targets the cervical nerves, will take care even of the deep. Why? Because the fascia is not completely impervious. It will let the drug seep towards the deep branches also. So we recommend the intermediate cervical plexus block. Okay, whenever you have to block the cervical plexus for doing a thyroid surgery or a parathyroid surgery. Okay, but if you have to block isolated cervical supraclavicular nerves, you can do at a little distance. Okay, so where do we actually start? Again, the starting point, thodi jali laga do, would again be supraclavicular fossa, but we'll move our probe cranially and try to reach the level of cricoid cartilage and identifying the tapering edge of the sternocleidomastoid. Okay, so can you identify this? What is this muscle? Sternocleidomastoid. What is the artery underneath? Dr. Manish is showing carotid. I release the compression. What is the vessel? IJV. I move a little lateral. Okay, can you see some little bunch here? These would most likely represent the branches of cervical plexus. Once you inject the local anesthetic 3 to 5 mLs, these would become much more brighter. Now let's identify the facial layers. The fascia which covers this sternocleidomastoid. What is this facial layer? Investing layer of deep cervical fascia. The fascia overlying the scalene muscles. What is that? These are scalene muscles. This is the prevertebral layer of the deep cervical fascia. In between these two, if you deposit your local anesthetic, your intermediate cervical plexus gets blocked. If you deposit around 10 mLs, the entire plexus would get blocked. If you just give 3 to 5 mLs at this level, only the supraclavicular nerves would get blocked. The classical literature recommends to block the entire intermediate cervical plexus at the level of C4. I'll tell you, go a little more cranial. As we keep going a little more cranial, you will see the division of the carotid into 2 branches. The medial one would be the external carotid and the lateral one, it has divided. The medial one is the external, the lateral one is the internal. I go more laterally and identify the tapering edge, now you can see some hypoechoic nodules, which Dr. Manish will point out. This represents the branch of cervical plexus. So if you deposit this at this place, the entire plexus is likely to get out. I come much more lower. I am coming lower at the level of little below the cricoid cartilage. Okay. Then if I deposit 3 to 5 ml, then I'll get a isolated supraclavicular. So for shoulder surgeries, do we need to block the entire plexus? The answer is big no. So you would do a interscalene or a superior trunk block combined with a supraclavicular nerve block, which Dr. Shiva Shanmugam and colleagues call it as a SCUT block. SCUT is an acronym which stands for, SC stands for supraclavicular, which are branches of cervical plexus, plus UT. UT stands for upper trunk block. Is it clear? So with this, I finished the sonoanatomy master scanning above the clavicle. Now I'll move below the clavicle. So what is the volumes which you use in your practice for performing a supraclavicular brachial plexus block? Anybody? For anesthesia and analgesia. Please.
0.25% fluocaine, 15 ml and 10 ml of lidocaine.
Okay, that is you are using for anesthesia. Okay, any other difference in opinion? I think let's make it interactive. There's nothing wrong or right. Okay, it's your practice, you are doing it, you are getting anesthesia. So anybody has a different opinion, they would like to give, what is the volume you are using? Whosoever is performing. आप सर कितना देते हो इंटरस्केल? हाँ? Of? For anesthesia or analgesia? Okay. So how long do you have to wait to get anesthesia? 20 minutes, 30 minutes? Okay. So you're using ultrasound guidance or a PNS? Okay. So I would request with ultrasound you can dead drop the volumes. Yes, Dr. Manoj.
0.5% and 10 ml of 2% xylocaine to get an immediate effect. So I should not have to wait for 20 minutes for the effects. So
Okay.
the total volume 25 ml.
Okay.
And for analgesia, either I go for the 0.2% ropivacaine or 0.25% of the bupivacaine, 15 to 20 ml for
Okay.
analgesia.
So now under ultrasound guidance, my dear friends, since you are able to identify neural elements, now you are better off. I've told you the sweet technique. You are able to identify the superior trunk C5. You can drop the volumes. The volumes which we recommend, okay, for anesthesia for interscalene level is 6 to 10 ml. I'll carry on with this discussion. They are ready upstairs. Yeah, please. So we have covered up till now.
Devesh, sir, there is one question from the audience.
Yeah, please. Okay, sir, I'll explain you. So we should not label nerve as hyperechoic, first of all. It's like, okay, there are vesicles, the neural elements which will appear hypoechoic. They are always surrounded by a connective tissue which will appear a hyperechoic, and this is known as the classical honeycomb appearance. The hypoechoic neural elements surrounded by hyperechoic connective tissue. But in the interscalene groove, the amount of connective tissue is very less. So that is why the nerve is appearing hypoechoic, the neural nerve roots. Okay, as they condense to form the individual nerves or the brachial plexus elements, they will have a more and more connective tissue that will give you a mixed appearance. Is it clear? We'll come to the median nerve. Median nerve will have a classical honeycomb appearance. C6 ventral ramus, C7 ventral ramus will have a hypoechoic appearance. Dorsal scapular, long thoracic, there were hyperechoic smudges. Is it okay, sir? Does that answer your question? Is it clear to everyone? Okay. So we have covered elements above the clavicle. And just a brief, I would request you to try to bring down the volumes which you have been using. Okay. So 0.75% ropivacaine, MEV 90, which stands for minimum effective volume, is just 6 ml. So for anesthesia purpose, use around 10 to 12 ml for interscalene, 12 to 15 for supraclavicular brachial plexus. The concentration being 0.5% ropivacaine would suffice. You need not add lignocaine. I am not questioning your practice. As anesthesiologists, we generally do not want mixology. Towards the day, we'll tell you what are the advantages and disadvantages of mixing. There are disadvantages also, there are advantages. If you feel it is advantageous in your practice, please continue using, but try to avoid mixing as far as possible. There can be different views to it. Dr. Manish might have a different view, Dr. Anil might have we'll have a discussion on that. So try to reduce the volumes. You need not use 25 mLs. For interscalene 10 to 12, for supraclavicular 12 to 15 for anesthesia purposes. And for analgesia, for interscalene 6 to 7 mLs is more than sufficient. What he has used as a superior trunk, just 5 mLs, because it's an analgesic blocks. Once he comes downstairs, we have a good panel discussion. We'll ask him what is his like. I use 6 to 10 mLs for superior trunk for anesthesia, but for you guys to be on the safer side, your block should not fail. I'm recommending a little higher dose, but certainly requesting you to cut down the volumes. Is that clear? So now coming on to the blocks below the clavicle. The classical one is the infraclavicular, which blocks the what? Cords or what? Cords. So there is something called as costoclavicular block. Are you aware of that? Who is aware? Raise hand, it's a discussion please. Nobody, okay. So what happens is, as we go behind the clavicle, the trunks and divisions which we have shown you as a bunch of grapes, reorganize and form the 3 cords. What are those 3 cords? Lateral, medial and posterior. Infraclavicular you are all aware. Infraclavicular we approach at a pericoracoid approach. That means I will place my probe just medial to the coracoid process. If I go a little more medially, there is a costoclavicular space in which Dr. Karmakar prescribed the costoclavicular block in 2015, where also we are targeting the cords, but the cords are just clustered next to the axillary artery. First I'll show you the classical infraclavicular block, which you are all aware. Then I'll show you the costoclavicular block, and you will yourself realize the differences between these 2 blocks. So in order to perform the infraclavicular or costoclavicular, okay, the position supine, head turned towards the opposite side. Is it okay? So the position, best position is shoulder abducted at 90 degrees. Can you see for yourself? Idhar pura ye wala dikhao. Okay? Elbow flexed, and this position in literature has been described as Houdini's clavicle. Houdin, Houdini's clavicle. The beauty is, if you see, the clavicle moves superiorly. If his hand is like this, okay, clavicle is here. आप ऊपर हाथ ले आते हो धीरे धीरे, लाओ ऊपर लाओ और लेते हो, अब देखो clavicle ऊपर जा रहा है कि नहीं जा रहा, कीप और ऊपर ले आओ बेटा, ऐसे करके ले आओ. So clavicle moves out of the way. The plexus becomes more superficial. Does that mean I cannot perform infraclavicular brachial plexus block with arms by the side? I can still very well perform. But costoclavicular I will not be able to perform. I'll show you the differences and all this like. So the beauty of infraclavicular is, if there is a fracture patient who cannot abduct, still you can. If there is a soft tissue injury for which you are giving a block, preferably give this position. So next step is feel for coracoid. All of you can do it. First feel for your humeral head, and just medial to that there is a bony.
Betadine please.
Sir.
Betadine please.
Okay.
Can I use a camera cover? Please remove that.
So we are hearing some voices from the operation theatre. I hope you are
Depth thoda.
Same side. Yeah, we'll do that also. But isko niche karna hai na.
Okay, so I have placed my probe in longitudinal orientation, my dear friends. Okay, the left hand of the screen is caudal, the right hand of the screen is cranial. The probe is placed medial to the coracoid process. Okay, if I move my probe a little cephaloid, I would see the clavicular shadow, okay, which I do not want to see. So the muscle which you see on the top is the pec major, which Dr. Manish is pointing out. The muscle underneath is pec minor. In between these 2 muscles, you are seeing some vasculature. These are pectoral branches of thoracoacromial artery. If you have to perform a pecs block, the same position you would start, then you would move your probe in a different direction. When you come to trunk, we'll explain you that. The next advantage is, can you see for yourself a pulsatile structure? Pulsatile structure, which is the axillary artery. Just caudal to it, there is a compressible structure, that is the axillary vein. At this position, we can see for ourselves the cords are clustered around the axillary artery. Okay, so let me do a little juggling. Okay, so the cord, this structure which you are coming across would be the lateral cord. Okay, the in between these two or somewhere here would be the medial cord, and here would be the posterior cord. Right now, what you are seeing is a smudge. Can you appreciate this smudge? The moment you start injecting the local anesthetic, these would separate out. So my needle would come from this place, from cranial. Okay, and first I'll try to give some local in this place. I do not wish to injure it. I'll find a path, inject some local around it, so I'll get a decent path to go towards the posterior cord. What should be the aim of distribution? Has any one of you given an infraclavicular block? No. So the aim has to be U-shaped distribution around the artery. If it's a J-shaped distribution, that means the other side of the U is still left. You have to manipulate your needle in such a way that the other side gets curved. Are you getting the difference between U and J? U means around the axillary artery. If I am not getting a U here, so I'll arch my needle back upwards and come here and make sure that the local anesthetic spreads here also. But in literature it is recommended that if you deposit classically at 6 o'clock, you will get a U-shaped distribution, and this is what is our practical experience once we give. This place is quite deep. The needle trajectory is quite steep. As a beginner, you might not be able to appreciate that. And it's a high volume block. You will have to use around 15 to 20 mLs, even with ultrasound. And if you are intending to give blind or with PNS, 30 to 40 mLs would be required. So ultrasound does help you to cut down the volumes. That's what I wish to emphasize for all of you guys. So next important step is underneath the axillary artery. Can you see some shimmery structure? ये दिख रहा है आपको? So pleura is quite close by. But how close? Now in order to visualize the pleura, I have just tilted 5 degrees medially. If I was keeping perpendicular, it was not that close. This was the rib underneath. The white hyperechoic is the rib. If I tilt my probe 5 degrees inside, I see the pleura. So thereby meaning stay close to the coracoid process. Okay, avoid medial tilting. Okay, try to visualize the structures of interest. This muscle, what is that muscle? Serratus anterior muscle, because it originates from first to 9 ribs. Okay, thanks Manish for reminding me. So infraclavicular is clear. This is the pericordicoid approach. Now what Dr. Manoj Karmakar said, that this block is quite a deep block. Your needle trajectory is steep. You are not able to visualize all the cords separately. Let's go a little medial. This is known as the lateral infraclavicular fossa. The medial side is known as the medial infraclavicular fossa. In order to perform that, the position has to be same. But now I'll keep my probe in transverse oblique orientation. Okay? So the scanning sequence is very similar. Okay? But now I'll scan first at the level of clavicle. ये clavicle shadow दिख रहा है आपको? I'll now slide my probe off the inferior edge of the clavicle. I am sliding. I have almost reached. Okay? Can you see on left hand of the screen, my dear friends, is medial. Can you see the axillary vein? Can you see the valves inside it? Can you see the axillary artery sitting next, right on the right side? Okay? The muscle on the top is pec majors. Next is subclavius. Muscle underneath the artery is the serratus. Next to the artery, can you appreciate the bunch of, I would not call it as grapes, although they are a mirror image of supraclavicular brachial plexus. Do you realize? ठीक है, अब इसको हम decipher करेंगे. Can you see the hyperechoic structures? This is the lateral cord, this is the medial cord, this is the posterior cord. How do I say it? Because of the anatomical knowledge. Dr. Karmakar has shown that the lateral cord is situated in the anterior compartment. There, white line you can see. This white line is the septum, which divides the anterior compartment from the posterior compartment. The posterior compartment has a medial cord. This is the posterior cord. So the way I remember is LMP. Easy? Lateral cord, medial cord, posterior cord. Lateral cord is the most anterior one. Medial cord is situated next posterior to it, and the posterior cord is the most outer one. Okay? So my needle is going to come from the lateral side. Okay? From this side, and make sure that I deposit the drug in 2 compartments. Is it clear up till now? Now the OT is ready. We'll start again with the costoclavicular and go to individual nerves. Okay? Thank you. So for costoclavicular, what I was saying is, again, Houdini's clavicle is must. Whereas for infraclavicular, you can have a adducted position also. So he has already demonstrated the infraclavicular brachial plexus. Now I think your concept would be clear. Now in order to do scanning for costoclavicular space, there is a 3-step approach. Okay. First, you keep the probe over the clavicle. Okay. Just slip it off the inferior edge. Okay. With a slight tilt into the neck. Now contrasts. For a supraclavicular, what we were recommending, a slight tilt into the thorax. For costoclavicular, what we recommend is a slight tilt into the neck, so that as the neural elements are crossing behind the clavicle, we can visualize them well. Right now it's perfect perpendicular. Can you see a vein coming into the cephalic vein? Sorry, the vein coming into the axillary vein? I am in a perfect perpendicular orientation. This is known as the classical tadpole sign, where the cephalic vein enters the axillary vein. If you are visualizing this position means you cannot give a costoclavicular brachial plexus block. I have to tilt my probe to slightly 2 to 5 degrees looking into the neck. As I do that, the vein is gone. Okay. And another thing happens, the plexus becomes more prominent. Can you appreciate? अभी मैंने adjust कर रहा हूँ, 1 second. Now can you appreciate the lateral, medial and the posterior? नहीं, वो G वाली में. Okay, this is the place. So my needle will come from the lateral side. Okay, so if you see the vein view, would you like to give the block? The answer is big no, because your needle will come through the entire vein. Although still I am seeing the plexus, but the needle will come through the vein. That means I have to move a little cranial, maybe just half a centimeter, and a little tilt into the thorax. Sorry, into the neck, and you can see for yourselves. Okay? So now next we move to the axillary brachial plexus block. Again the position has to be supine, shoulder abducted to 90 degrees, elbow can be flexed to 90 degrees. So where do we actually place the probe? Can anyone tell me? किसने दिया हुआ एक्सिलरी ब्लॉक? हाँ, कहाँ प्लेस करते हैं आप? एक्सिला में. So axilla is a armpit is a big portion. Can you focus on there? कहाँ करूँगा? यहाँ करूँगा, यहाँ करूँगा या यहाँ करूँगा? There has to be some specific landmark. Where you see the insertion of the muscles, you keep the probe. So can you decrease the depth? What is the structure we need to identify? Conjoint tendon. Humerus is definitely seen, no doubt. The structure to identify is the conjoint tendon. If my conjoint tendon is not visible, should I be giving my axillary brachial plexus? Answer is big no, because the nerves would have already left. So this one thing you have to remember, this is the conjoint tendon. I am keeping the probe with little compression. You can see the axillary veins getting compressed. Okay. So what is the relationship of the nerves? Between 6 o'clock to 9 o'clock would be your radial nerve sitting right on the conjoint tendon. Close to that would be the ulnar nerve between the axillary vein and the artery. Here is the median nerve, okay, sitting on top of it. So you can do a perineural or a perivascular. As a novice, if you are able to not recognize all the nerves, do a perivascular injection. just surround the artery by 15 to 20 mLs, you will be good to go. But we are students of RA, we learn from conferences. Now we are able to identify the neural elements. So we can do a perineural block. What about the musculocutaneous? Can somebody identify? इनमें से कौन सी है? कहाँ पर होगी? कौन सी मसल में होगी? So this is the biceps. So am I at the conjoint tendon? No. But can I see some nerve traveling? So at times, at the level of conjoint tendon, you might not see the musculocutaneous. It's okay. So I have moved the probe a little caudal and I am able to appreciate it sitting in the substance. So my needle will come here. So what is the volume I recommend? 3 to 5 mLs per nerve. You are blocking 4 nerves. So ultimately 15 to 20 mLs should be good. Is it okay? Okay. Now we'll stop here. Now we'll switch over to the leg. Enough of upper limb we have covered. If time is left, we'll scan the distal nerves also. Now
You can scan the distal nerves also right now.
Okay. Okay. So आप थोड़ा सा उधर shift हो जाओ. थोड़ा सा उधर जा. इधर shift हो जाओ. Okay. So when we talk of थोड़ा सा उधर हो जाओ, आपका हाथ दर्द हो जाएगा. Jelly. So for the distal nerves we are aiming at which all places? 3 important places. The mid-humeral, antecubital and the mid-forearm. Why do we need a distal nerve blocks? In case once I have given a proximal brachial plexus, I test my individual nerves. In one of the particular territory, the nerve has escaped. So I can do a distal nerve block. Or we are in the era of being procedure specific. For example, if the surgery is happening on the radius through the volar approach, infraclavicular भी दे सकते हो, axillary भी दे सकते हो, supraclavicular भी दे सकते हो. Would I like to give? No, because it would block my proximal muscles also for analgesia. So I'll go a little distal. So I can do a median, radial and LSEN block which are exclusive for that incision. So this is the level we are right now into it. We are not going more proximally, we are going as distal as possible. So I'll start with the antecubital fossa, which is the easiest. Okay. So my probe is placed in the antecubital fossa with the left hand of the screen being medial. Okay. Left hand is medial. Can you see the pulsations of an artery? Can somebody appreciate? Yes or no? तो हमारा रिलेशनशिप क्या है नर्व्स का? मीडियल टू लैटरल. एक निमोनिक है बड़ा क्लासिकल, MBBS या MBBR. What is that? यार कुछ तो बोलना पड़ेगा यार. Okay, so let's start. What is this? The joint line. The muscle sitting on the top is the brachialis. Okay, as I go lateral, the muscle on this side is brachioradialis. Okay, so in the same field of vision, we'll be able to identify starting from medial to lateral. First is median nerve, which would be situated medial to the brachial artery. Can you identify the artery, please? Yes or no, madam or sir? ठीक है. What is this structure? Honeycombed. Median nerve. This is what? Brachial artery. Can you see a vein getting compressed? This is the cephalic vein. Underneath is the LACN. Okay. As I move laterally, can you see this structure? What is this nerve? Radial nerve. Operating room is ready, so we'll switch over to the operating, then we continue. Now we have changed the machine. We are going to use a G machine. Let's see whether I am going to demonstrate the same or not. So we'll be focusing again on the distal blocks, and then I hand over to Dr. Manish. for front of leg, then back, and then if time is left, trunk and abdomen will do the master scanning, and then on tomorrow we'll have a respective station, so you'll get a good hands on. इसको ये off कर दो सारे. I don't want. मेरे touch करने से on तो नहीं हो जाएंगे. I want them. होगा ना touch. That's why make them defunct. Otherwise it will keep happening. And now preset.
We have changed the machine from Sono side to G.
थोड़ा सा उधर हो जाओ, थोड़ा सा उधर, तेरे हाथ दर्द ना हो.
Dinesh sir, till the time the machine is ready, can we, so what is the best block to put in a catheter in the supraclavicular area or the
Okay,
acoustic?
so if you wish to do catheters for upper extremity, then supraclavicular and interscalene are not good sites because the catheters would come out. Infraclavicular and a costoclavicular are good sites to place catheters. So this is how.
And there is one more side which is the superior trunk, sir.
Yeah, but chances of
No,
removal
superior, हाँ. No, superior
Dislodgement
trunk.
is like.
Superior trunk is a beautiful catheter placement
No,
side
no,
now.
catheters we can place anywhere. I'm talking in perspective of whether they would stay there for long or they would get dislodged.
They will stay there.
So, unfreeze. Okay. So this happens once you are not used to such machines and you are asked to demonstrate.
Can I request the audiovisual guys to please readjust the PIP?
Yes.
Yeah.
So, okay. So left hand of the screen, my dear friends, is medial. Right hand is lateral. I have placed my probe onto the antecubital fossa. The image structures, same volunteer, the way it is appearing is little different. Can you increase the gain, please? Okay. This is the artery. This is the median nerve. The muscle sitting right next is the brachialis. As I go laterally, can you see the cephalic vein? Can you see these two hyperechoic smudges? These represent the Elysian. Okay. Can you see a nerve? This is the radial. It is always accompanied by a perforator artery. So as I move distally, you would realize that the radial will divide into two branches. Okay. The deep branch, in order to identify, I have to keep the arm in little mid-prone position. It will dive towards its supinator, whereas the superficial radial nerve will continue alongside the lateral aspect of the arm. Okay, keep a watch, the artery is separating, okay. The deeper one would I'll again trace. Okay, okay. Is it okay? Now keep a watch. Can you appreciate? It is diving towards the supinator, and as I come towards it, so this is the place if we recommend to block, if you need to block the SRN, that is the superficial as well as the deep. Now let's come on to the classical mid-forearm approach. Mid-forearm, if you keep, you will be able to identify all these nerves. थोड़ा गेन कम करो. Come, reduce more. So the moment I keep the probe in the mid forearm, the brightest honeycomb structure which I see is median nerve. Now sir, just to answer your question which you had asked, now you realize this is a combination of hypoechoic plus hyperechoic. So this is the honeycomb appearance, where the hypoechoic represents the neural elements, this represents the connective tissue element. So if I have to come, I should not be aiming at the trunk, I should be aiming at the sides, because all the nerves are situated in musculofacial planes. Is it okay? So if I move my probe little laterally, can you appreciate a pulsatile artery? This is the radial artery. Radial nerve, superficial radial nerve is situated here. Now I move my probe proximally towards the antecubital fossa. Okay. Can you appreciate? Now I am getting again towards the mid forearm. Now you see the radial nerve will be separating from the artery. As a novice, I do not recommend that you perform the block here because you might injure the artery also. So as a novice, I would recommend just scan a little proximal and distal and stay away from the artery. So just to confirm that the radial nerve is radial to the radial artery, the ulnar nerve is ulnar to the ulnar artery. Okay, I'll move a little medial. Okay. Now as I move medial, what vessel should I be seeing? मीडियल साइड पे कौन सा वेसल आएगा?
थोड़ा वाइड इंक्रीज कर देना, गेन इंक्रीज कर देना,
ढीला छोटा. अल्नर आर्टरी आएगा कि नहीं आएगा?
बस 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 बस.
ओके. So 1 second, I'll go back again just to confirm. Median nerve, radial artery, same, I'm going medially. Ulnar nerve तो ये ulnar artery I'm not able to visualize.
थोड़ा नीचे आएंगे तो आ जाएंगे. लगता है इसका डिस्टली इसका थोड़ा.
एक second, let us trace from the brachial artery से ये brachial से trace कर लेते हैं. Ulnar nerve is this. Can you appreciate? This is going behind. चला गया, मैं olecranon पे आ गया. This is the ulnar nerve. This is the ulnar nerve. Ulnar nerve. Ulnar. Okay. Vessel somewhere, I think I'm not able to find out. होना तो चाहिए, ऐसा तो नहीं है, नहीं होगा. Now coming on to the median, as I go distally towards the carpal tunnel, keep watching this. Dr. Manish is pointing, keep watching. It will gain entry. Depth कम करते चले जाइए आप. 1.5 सेंटीमीटर पे ले आइए. Depth. जी guys.
डेप्थ कम करो, थोड़ा सा गेन कम करो. सुपरफिशियल आना है हमने भाई.
Can I request somebody to assist them, please? We are doing a master demo. So this is the median. Keep watching. This will rise up and get into the carpal tunnel. Are you watching? अब हम इस समय कार्पल टनल पे पहुंच गए हैं. सो whosoever is practicing chronic pain, Dr. Manish, he like to share his experience. How do they do the hydrodissection in this place and all this? Okay. So I'm coming out of the carpal tunnel. Okay. अब डेप्थ बढ़ाते जाइए. 3 सेंटीमीटर कर दीजिए. Yes. So this is median. Tracing back towards. एक और डेप्थ बढ़ा दीजिए. Can you appreciate? The median nerve comes in close relation. This is the ulnar artery, which we were finding out. अब almost अब मैं antecubital fossa में पहुंचने वाला हूँ. This will dive up and it will move close to. अब देख रहे हैं dive कर रही है, ऊपर जाती जा रही है, and then it will come and lie close to the. थोड़ा सा गेन बढ़ा दीजिए. It has reached. So again I'll trace for you antecubital fossa, median nerve, keep following. Keep following, it dives down, down, down. It comes in close relation to the ulnar artery, then comes here. Okay. And I go more medially, again trying to trace ulnar artery. Somewhere. So now we'll start tracing from the arm till the antecubital fossa. Mid-humeral approach भी करना है. So median nerve is like श्रवण कुमार. वो अपने पेरेंट्स को कभी नहीं छोड़ती. Who's the parent? Brachial artery. So it will run in the close relation. Okay. So in the antecubital fossa, where was it located? Medial. Axillary में कहाँ है? Lateral है. So mid-humeral level पे it will cross from lateral to medial side. So okay, let's trace. Jelly दे दो please. Okay. So we'll start from antecubital fossa.
Yes, sir.
ठीक है. मीडियन आपको दिख रहा है, एंड आई विल कीप मूविंग अप, मेकिंग इट इन सेंटर. अब देखो आर्टरी के ऊपर अब जाएगा ये. इट्स क्रॉसिंग, कैन यू अप्रिशिएट? नाउ इट इज कमिंग लैटरल. कैन यू अप्रिशिएट? ओके. डॉक्टर मनीष पॉइंट, एक डेप्थ कम कर दो. अब बिल्कुल लैटरल है. अब मैं मिड ह्यूमरल में हूँ, ठीक है. अभी मैं एक्सिलरी फोसा में जाऊंगा, तो आप देखना कैसे वहीं पर ही रहेगा उसके साथ. Can you appreciate? It is almost, I have reached the axillary brachial plexus. Conjoint tendon दिख गया आपको? Okay. Now coming on to the radial nerve. So in order to identify radial nerve from its exit, the arm has to be, can you focus? Okay. Arm almost by the side of the trunk, elbow flexed, and somewhere in the mid portion. Okay. So we'll try to visualize the exit of the radial nerve from the spiral groove. Axillary से कहाँ जाता है? Spiral groove में पीछे जाता है. अब हम यहाँ से हम exit visualize करेंगे. So left hand of the screen, my dear friends, is anterior. Okay. Right hand is posterior. So muscle on the right side would be triceps. Anterior में brachialis, brachioradialis. Can you see a hyperechoic smudge along with the vessel? Okay. As I move distally, it will cross. Can you see something crossing? Something crossing? Can you see something crossing? This is the radial nerve. I'll go back again, go back again, go back again, go back again. This is in the spiral groove. Spiral groove is closely opposed to the humerus. Can you see it is closely opposed to the humerus? While coming out of the spiral groove, it gives rise to a PACN, that is a cutaneous branch. अब देखो उसने दे दिया, ठीक है. ये हमारे रेडियल है, PACN ऊपर जाता जा रहा है, ये यस. कैन यू अप्रिशिएट? यस. दिस इज गोइंग अप एंड फाइनली इट विल पियर्स द फेशिया एंड इट हैज एंटर्ड अ ट्रिपल FT. इट्स अगेन अ फ्लैट फिल्टर. इज इट ओके और नॉट ओके? कन्विंस्ड? चलो. नाउ आई वुड रिक्वेस्ट डॉक्टर मनीष टू गिव डेमो ऑन द एंटीरियर हाफ ऑफ द लेग. And then some blocks are left, then posterior half and trunk and abdomen we'll try to cover. हाँ सर, पहले मनीष यू डू अच्छा आप पोस्टीरियर कर दो सर पहले.
सर आई डू द पोस्टीरियर, आप एंटीरियर. पहले आप पोस्टीरियर कर लीजिए सर. एंटीरियर. अरे सर आपके सामने. इट विल बी इजीियर टू डू इट. आप एंटीरियर. पोजीशन लैटरल चाहिए, पजामा थोड़ा नीचे करेंगे इनका. एक काम करो बेटा, सुनो सर, आप ना ऐसे करवट ले लो अपना. करवट ले लो.
So, very good morning to everyone. Sorry I was not there today morning to meet you, all of you. And I think because I went to bed yesterday around 1 and today I got up at 5 and I have been running from pillar to post. So we wanted to show the maximum number of blocks that can be possible. I know it makes sense to do it chronologically, anatomically, but then again have to consider that we have take the management into considerations that we will only put orthopedic and plastic surgery cases. So there are few cases where surgeons had put because of the patient's request, and anyway we needed this thoracic and abdominal blocks. So my target was to show you the maximum possible blocks in the best possible hands, because then you know what to do and more importantly what not to do. So so that is the going forward. Now after this in the masterclass still we are going on, we will be showing now we have 2 cases below. One will be doing a thoracic paravertebral for a showing in a lap coolie patient, but we will be doing a thoracic paravertebral. And after that we will be doing a proximal humerus, so we will be putting a catheter. So that we will be showing how do we put an e-cath. And if required, we might go in for another prone patient ultrasound guided epidural. We are trying to figure that out. So only 3 patients now left for live, And these patients, the masterclass will go on. The lunch will start at 12:30. The lunch boxes will open. At 1:30, the sessions will start. So we need to finish on time. Thank you so much. I request Dr. TVS sir. So sir reached yesterday the hotel something around 11:30 in the night. So, and today morning at 7, sir was all okay, up and running. So I request sir to, so that sciatic part, Dr. Devesh Bhai had to join, but he reached pretty late. So, and he has some bad health. So he'll be joining in second half only. Thank you. Over to you, sir.
Yeah, thank you. Good afternoon to all of you. My flight from Hyderabad to Delhi took 1 hour 40 minutes. And my journey from T3 to Greater Noida took 2 hours 5 minutes. So, what we'll be doing is scanning the back of this patient. Now, as I showed when I did the sacral plexus block, we palpate this bony landmark, which we call the posterior superior iliac spine, and then we join a line connecting to the greater trochanter. And I place the probe in this manner on the medial part of this line. Now what we see there is the uninterrupted line of bone, which is the ilium. Now overlying the ilium would be the gluteus maximus. That's fine. No, reduce it. Reduce it. Reduce. Yes. You will see the gluteus maximus muscle, and below that would be the gluteus medius and minimus. Now I do a parasacral shift towards the sacrum, which is called the parasacral parallel shift, which is the PSPS. And as I do that, you will see that there is a break that is appearing in the bone. And there, now medially would be the sacrum. Now let us see which is medial. This is medial, right? So that is the sacrum. And on the left side of the screen is the posterior border of the ischium. Now here you will be able to see the sacral plexus beginning to take off. Now can someone please show it here on the monitor? You are showing on the screen? Okay. You see the sacral plexus take off under the hypoechoic piriformis muscle. The sacral plexus exits the greater sciatic notch under the piriformis muscle, and in the vicinity of the sacral plexus, as I told you this morning when we were doing the live demo, that there is a pulsation which you can see, which would be the superior gluteal artery. So that is the giveaway to locate the sacral plexus. And the hyperechoic fascial line towards the bottom of the screen would be the peritoneum. So this is what you would like to do when you do what we call a parasacral parallel shift. So I'm just going back. Now you see the direct line, which is the ilium. And as I scan towards the sacrum, you will see this sort of an appearance, right? So this is how you would identify the sacral plexus, which is the most proximal approach in the back of the leg. Now having identified this, now if you see this mark here, this line typically starts at the midpoint of the line that connects the greater trochanter to the posterior superior iliac spine. And if you drop a line downwards by about 5 centimeters.
Gopal sir?
Yes?
Can you, sir, just sorry for interrupting you, sir. Just as this has just begun, the sacral plexus that you have started showing, we have the patient ready with the thoracic
please go ahead. We'll switch. So we've identified the sacral plexus. And now we come a little distal. Now if you see this line, this point of entry is called the classical Labart's approach. This is where you will be able to identify the gluteal sciatic nerve. So if I put my probe here, And can you lock the trolley, please? Can you reduce the depth? Can you reduce the depth? Reduce. Yes, yes. Just reduce the gain a little. Can you, somebody lock the trolley? Okay. Can you freeze this image? So if you see here, that would be the bone over there. That would be the sciatic nerve over there. That is the gluteus maximus. And this muscle which this nerve overlies would be, to begin with, the superior gemellus. A little lower down it will be the obturator internus, and a little lower down it will be the inferior gemellus. And then you reach the subgluteal sciatic level, wherein the nerve lies in between the gluteus maximus and the quadratus femoris. So I'll just go a little distally now to the subgluteal space. Now for that, please unfreeze it. We start by identifying the greater trochanter. Can you increase the depth a little? Depth. Yeah. No, let's reduce it. And having identified the greater trochanter, I swing my probe medially towards the ischial tuberosity. Now, if you can see this, to the left of the screen is the greater trochanter, and to the right of the screen is the ischial tuberosity. Now, if you can imagine, it is as if a man is lying on a hammock. So both the bony landmarks are either ends of the hammock. Now, if you look in the center of the screen, just below the gluteus maximus muscle and above the quadratus femoris, you will be able to see the sciatic nerve there. Can I just freeze this image and show it to you? Thank you. So this would be the greater trochanter. This would be the ischial tuberosity. That's the skin, that's the subcutaneous tissue. This would be the gluteus maximus. This is the quadratus femoris, and that would be the sciatic nerve. And in the vicinity of the sciatic nerve, you will see a small pulsation, which in this case would be the inferior gluteal artery. So this is how you get the view for the subgluteal sciatic nerve. And having done this, I'll switch my probe and I will go on to the popliteal sciatic, which is a very basic level block, which I am sure most of us perform in our clinical practice. Gel, please. So I'm just scanning proximal to the popliteal crease. Increase the depth. And the idea would be to scan distally. Now, what you can see is the pulsation of the popliteal artery. And you see a hyperechoic line with a shadow, which would be the tibial bone, under which there is an acoustic shadow. And just posterior to the pulsatile popliteal artery, you see the sciatic nerve. Now, laterally, you will have the biceps femoris, and medially you have the semimembranosus and semitendinosus. So if you just scan distally, at some point you should be able to see the sciatic nerve split. The split will occur into the larger tibial component and the smaller peroneal component. So there you can see that the peroneal component is taking off. And if you go even distally, you will see that the peroneal component is moving away from the tibial component there. The peroneal component has moved away from the tibial component. Now that is the ideal place to do a sciatic nerve block in the popliteal fossa would be here, where you just see the split of the sciatic nerve into the peroneal as well as the tibial components. See, that is the place where the split is beginning to take place. All right? So this is how you would identify the sciatic nerve in the popliteal fossa. So I think that's about it as far as posterior is concerned. So over to Dr. Manish. He will be showing you the neural structures in the anterior aspect of the lower limb.
Thank you very much, sir. Thanks for the demonstration.
Can you please?
I always feel that why TKR pain is more than the elbow fracture pain,
Repeat.
and why TKR pain is still more than the
पैर
DHS
सीधा
pain.
कर लीजिए, पैर सीधा कर लीजिए.
There is a simple answer to it. The upper limb is supplied by only one plexus, which is the brachial plexus. Whereas the lower limb is supplied by
इसको बाहर निकाल दे.
by two plexuses, which is the lumbar plexus as well as the sacral plexus.
इसको बाहर निकाल दे.
If we simply have in our mind the distribution of the lumbar plexus components and the sacral
सीधा
plexus
कीजिए.
components, then each and every block that we
Yes,
want to
yes.
give to do a particular surgery done or to get a relevant analgesia in a particular area that is below knee or above knee, then we can have all our answers and all our choices of block. A simple explanation to this, that for which surgery which blocks needs to be given, lies in the sign of Mercedes. Everybody loves Mercedes car. Okay, so the Mercedes sign is like this: a circle, a straight line, and then two lines, leg shape. Rotate this sign. Rotate this sign. Okay, rotate it. The anterior part has the quadriceps. The middle part has the adductors, and the posterior part has the hamstrings. Okay. From the sacral plexus, we have the sciatic nerve, which is the major nerve. From the lumbar plexus, we have the femoral nerve, obturator nerve, and the lateral femoral cutaneous nerve of thigh, LFCN. Okay. The femoral nerve primarily supplies the anterior. Sciatic nerve supplies the posterior part, and the middle part is supplied by from the obturator nerve. Okay. So complete analgesia for the lower limb can be achieved proximal to distal, first by spinal, then by epidural, then by lumbar plexus and sacral plexus block. More distally, femoral nerve block, obturator nerve block, LFCN, and the sciatic nerve block. Okay, sciatic nerve block has been covered by sir. The lumbar plexus block has been covered. So we are only left with the femoral nerve components, the femoral nerve and the obturator nerve, and two other nerves, L1, L2, T12, L1 ilioinguinal iliohypogastric, and the genital branch of the genital femoral nerve. If time permits, then definitely we will cover all these nerves. Okay. Femoral nerve, I think day in and day out everybody is giving to give analgesia for the skin grafting purposes or other purposes. Let us scan. And there is one more thing. हमारे पूर्वज कहते थे ना, जंगल में खो जाओ तो नदी का रास्ता नाप लेना. नदी के साथ साथ रास्ता होता ही होता है हमेशा. कहीं पर भी नर्व खो जाए ना, वेसल्स को देख लेना. वेसल्स के साथ नर्व होगी ही होगी. बीट द femoral nerve और द sciatic nerve, pop sciatic block कोई भी देना है. ठीक है. Another teaching जो मैं कल से कहता आ रहा हूँ कि हमेशा लैंडमार्क गाइडेड अप्रोचेस को मत भूलिए. जो हमारी कन्वेंशनल लैंडमार्क गाइडेड अप्रोचेस हैं, लैंडमार्क्स को ढूंढो. लैंडमार्क के साथ आपको आपका स्ट्रक्चर ऑफ इंटरेस्ट मिल जाएगा. कैन आई हैव द पेन प्लीज? So first of all, we'll scan the inguinal area. To scan the inguinal area, we'll first of all mark the anterior superior iliac spine, which is the ASIS, and we'll mark the pubic tubercle. Okay, pubic tubercle and the ASIS. This is the line of the inguinal ligament.
Just beneath the line of the inguinal ligament is the inguinal crease. What mistake we do? We usually put our probe on the inguinal crease. Okay, we have to put our probe between the inguinal crease and the inguinal ligament. Okay, and first of all we will, and again now we will mark our linear probe, please. The femoral artery. Jelly, please. The femoral artery is the easiest identifiable structure which we can see in the inguinal area. And now I have told that keep your probe between the inguinal crease and the inguinal ligament. As we go down, what we will see that the femoral artery, which is will divide into two parts. One is the profunda femoris artery and the, okay. Now the femoral artery is divided into two parts. One is the profunda femoris artery and one is the main femoral artery. Okay. If we want to give the femoral nerve block, the femoral nerve will not be given at this place. The femoral nerve should be given proximal to the division of the femoral artery into the profunda femoris and the deep femoral artery. Okay. Coming more proximally, what we can appreciate the femoral artery along with the femoral vein, which is lying over the iliacus muscle, which is the iliopsoas muscle. Acha, you are saying? The iliopsoas muscle. The iliac fascia, when it comes medially, will divide into two parts. Okay, one will engulf the femoral nerve is present over the iliacus muscle, but beneath the fascia iliaca in a separate facial sheath compartment. So when we are keeping our probe here, we can see two fascias. One is the fascia lata and one is fascia iliaca. And the femoral nerve, which will be the crescent shaped nerve, is present just beneath the fascia iliaca in the proximal part. Can you appreciate? Yeah, this is the femoral nerve. This femoral nerve is in a separate compartment. So for giving the femoral nerve, we first have to pierce the fascia lata, then the fascia iliaca, lateral to the femoral artery. Okay, beneath the muscle, above the muscle. Now this femoral nerve is an analgesic block. If we give this block for a patient of fracture femur or the fracture proximal humerus or for the TKR pain, then definitely there will be a sort of motor weakness in the patient post-operatively, which may extend for approximately 24 to 48 hours, depending upon the concentration and the adjuvants that you use for giving the block. So there is a more propensity towards giving the motor sparing blocks for the post-operative analgesia. Okay, what can be the motor sparing blocks for the post-operative analgesia? That can be the adductor canal block or the Peng block and the Peng and IPA block that we can give. Okay. Hip articulations. Let us talk about the hip articulations first. The articulations of hip is supplied by the femoral nerve and the obturator nerve and some components from the sciatic nerve. So either we give a femoral nerve or an obturator nerve or a sciatic nerve to give analgesia to the hip, or what we can do, we can deposit our drug in a capsule which is surrounding the hip joint. Okay, if we surround the capsule with the local anesthetics, then all the branches which are going inside the capsule and taking out the sensory sensations will get blocked. Okay. The capsule is a round structure circumferentially. The anterior part of the capsule primarily contains the sensory supply from the hip joint. The posterior part of the capsule is primarily taken out the mechanoreceptor. They have the mechanoreceptors in it, and the sensory supply is on the anterior side. So if we place the drug anteriorly over the capsule of the hip joint, then we will block the sensory supplies from the femoral nerve as well as from the obturator nerves. Understood? Okay. Again, for giving the tank block, I practice chronic pain. A very simple way is to look for the femoral head. Look for the femoral head and deposit your drug just above the capsule. Alternatively, what we can do, we can keep our probe between the inguinal ligament and the inguinal crease. डेप्थ बढ़ा दीजिए, अच्छा थोड़ा सा डेप्थ बढ़ा दीजिए. When we keep our probe between the inguinal ligament and the inguinal crease, what we can see is the iliopsoas tendon and this is the iliopectineal bone. When I slide my probe just inferior to this line, the iliopectineal line, I see the capsule of the hip joint. Okay. A safer option would be to deposit the drug in this bone line, protecting the tendon of the iliopsoas muscle. Okay. So I can come either inline from lateral to medial direction or from medial to lateral direction, or I can come from outer plane approach and directly hit this line. But when I come from the outer plane approach and will hit the line, then I can injure the central tendon of the iliopectineal line. So my preferred technique would be from the lateral to the medial side, because ergonomically it is also better. But either way you can go from medial to the lateral side. So the fascias that we have covered is the fascia planes that we have understood as the fascia plane above the iliacus muscle, which is the fascia iliaca. So all the lumbar plexus, one thing, all the lumbar plexus components, they are coming from the lumbar plexus to the leg beneath the fascia iliaca. You understood? All the components, the LFCM component, the obturator nerve or the femoral nerve is beneath the fascia iliaca. If I deposit a large volume of drug beneath the fascia iliaca, then I will block all the components to give approximately 90% analgesia to the hip. This you all agree? Here comes the utpatti of the fascia iliaca plane blocks, which is called as the, and these fascia iliaca plane blocks can be given either superior to the inguinal ligament, proximal to the inguinal ligament, or deep to the inguinal ligament. So it is called as SI5, suprainguinal fascia iliaca plane block, or infrainguinal fascia iliaca plane block. अगेन रास्ता ढूंढने के लिए नदी को ढूंढ लेते हैं. फ्रीज हो गया बॉस. femoral nerve, iliacus muscle, fascia iliaca. अगर ये fascia iliaca है तो मतलब femoral nerve यहाँ पे है. थोड़ा lateral लाऊंगा, sartorius muscle.
Dr. Manish?
Yes sir.
Just interrupting you, sir, sorry. You are ready here in the OR. This is a 57-year-old female for left side problem.
And I know that what pain I went through, because my colleagues are unable to put in the catheter at that time. As per our experience, we didn't encounter any sort of infection because the surgeons itself are very finicky, you know. So they have already painted and draped that particular area for us, and we also do apply betadine for our aseptic precautions. We have kept it for the 7 days. Thank you very much. Now continue with our lower limb scanning. So we are discussing the motor sparing blocks to provide analgesia for the hip surgeries. Okay. And we are into the fascia iliaca planes, where I was telling that the drug can be deposited within the fascia iliaca, so that the obturator, the components of the obturator nerve and the components of the femoral nerve can be blocked. Okay. Again, look for the nadi, which is the femoral artery, the fascia ilaka. So the concept is, if I give the drug above the iliacus muscle, below the fascia ilaka, then that particular drug will spread to the femoral nerve in the analgesic doses, and the same drug, when I move laterally, will come beneath the sartorius muscle and will block this particular lateral femoral cutaneous nerve. Can you appreciate the LFCN above the sartorius muscle? So in the infrainguinal area, with so much of twists and turns, is it possible? If we give a 20 to 30 ml of drug, that particular drug will seep into the femoral nerve and also to the lateral femoral cutaneous nerve. Practically it is not, but yeah, it can be done. But definitely not the obturator nerve. Obturator nerve. Okay. The second thing is, I can scan in the suprainguinal area. I can trace my probe from the infrainguinal area, nadi kaangi hamari femoral artery, nadi femoral artery, to the suprainguinal area. Okay. So there is some sort of depth, or there is some sort of anatomical distortions which is attached to this sort of technique. What I will do, in the same position, I will turn my probe in the longitudinal plane. This is the femoral artery. So we can see that iliacus muscle is dipping over the pelvis, and we can appreciate, can you please do the color, this deep circumflex iliac artery. This is a branch of the external iliac artery which is coming above the iliacus muscle, but not in a plane of the iliacus muscle. So this particular artery is above the fascia iliaca. Okay. If I deposit my drug, if I insert my needle from the chordate to the capillate end, and deposit my drug, in the fascia iliaca plane, that is above the iliacus muscle, but below the fascia iliaca, and deposit my 12 to 30 ml of drug, then I will definitely block the femoral nerve and the lateral femoral cutaneous nerve. The point of interest is that whenever I will inject the drug beneath the fascia iliaca, the confirmation point is this deep circumflex iliac artery will come up. Okay, because we are not in the plane above the fascia iliaca, otherwise it should have engulfed the artery. Okay. Now the studies have shown that if we inject the 20 to 40 ml of drug, then also we can block only two nerves, the lateral femoral cutaneous nerve and the femoral nerve. Okay, but where is the obturator nerve? Some cadaveric studies have shown that if we inject 62 ml of local anesthetic or 62 ml of dye in this particular plane, in the fascia iliaca, then only we can block the obturator nerve. Okay, so this block is primarily for the femoral nerve only. Another advantage of giving the fascia iliaca plane block, there are two advantages. One, that a catheter can be easily placed. A catheter can be easily placed in the suprainguinal fascia iliaca plane blocks, in the plane, which is quite away from the surgical field. Okay. Second advantage is that the articular branches, the sensory articular branches of the femoral nerve, of the hip, will arise in a plane which is proximal to the inguinal ligament. So with a low dose of drug, with a low concentration of drug, you can block the sensory articular branches. Okay. So in the suprainguinal area, the suprainguinal fascia iliaca plane block can be given. In the infrainguinal area, definitely the femoral nerve block can be given, or the PENG block can be given, which we have shown. Or and again, if the incision is on the lateral side, the lateral femoral cutaneous nerve as shown can be given. Okay. Now for some surgeries, for example, the bladder tumor surgeries, or if we want to do a knee surgery under regional anesthesia, then obturator nerve needs to be blocked. Let us see how to block it. Again, look for the nadi, which is the femoral artery. नहीं ठीक है. Now instead of going lateral, as always, we'll go medial. Some muscle which will come is this is the pectineus muscle. Still medial, we'll look into the medial compartment of the Mercedes, where all the adductors will be there. So we'll see the adductor longus, the brevis and the magnus, the brevis longus and the magnus. So we can appreciate this pectineus muscle and the three muscle groups. Okay, so this is the pectineus muscle, adductor brevis, the longus and the magnus. Anterior obturator nerve divides into two, the anterior and the posterior divisions. The anterior obturator nerve will be between the pectineus, the brevis and the longus, and the posterior obturator nerve will be between the longus and the magnus muscle. When we see the interior wala plane, this plane, we can also appreciate a simple artery. Okay, so this is the plane for the anterior obturator and this is the plane for the posterior obturator nerve. So either we can deposit the drug in the anterior obturator, above the anterior obturator and the posterior obturator, or what we can do, we can slide a probe in the proximal direction. Okay, we are moving towards the obturator groove, and in this obturator foramen, we can. भैया दर्द तो नहीं हो रहा आपको? This particular procedure is quite painful when we are giving the proximal obturator nerve. I will not try in this subject, but yes, in the obturator foramen, the obturator nerve directly can be blocked before dividing into the anterior and the posterior divisions. Okay, great. Now coming into the middle of the Mercedes. Our main concern nowadays is to get the TKR pain relieved, which is supplied by the anterior, which is supplied by the sacral as well as the lumbar plexus. Okay. And the most common block which is performed nowadays is the adductor canal block. Adductor canal block. वो हम कैसे लगाते हैं adductor canal block? हाँ, कुछ नहीं है, थाई का मिडल है, ASIS है, ये है, सेंटर में रख देते हैं. यहाँ पे रखा, क्या आया यार साथ में? ठीक है, हमें क्या नजर आया? सार्टोरियस मसल, उसके नीचे आर्टरी, उसके नीचे. सो दिस इज द एडक्टर कैनाल. आर यू श्योर? Now the knee is supplied by primarily three plexuses: the popliteal plexus, which is the prepatellar plexus, and the subsartorial plexus and the popliteal plexus. Okay, which has the components of the sacral plexus and the nerves. Okay. Now coming on to the first, the anterior wala plexuses, which is the prepatellar plexuses and the femoral plexuses. So definitely we need to block the components of the femoral nerve, and it's saying that you would deposit the drug in the femoral nerve or on the distal branches where all the muscular branches has left the femoral nerve, only the sensory branches. Okay. When we place a probe in the midline between the ASIS and the patella, we say this is the adductor canal, but this is not the adductor canal, this is the distal femoral triangle. We are giving the block in the distal femoral triangle, not in the adductor canal. Okay. Again remember the Mercedes sign. Adductors are located in the medial compartment, okay, which have the adductor brevis, longus and the medius, and the vasta are located in the anterior compartment. Understood? Okay. The brevis will fall off in the proximal part only. Okay. If we are keeping a probe in the middle between the anterior and the middle compartment, so on the lateral side will be the vasta, and on the middle side will be the adductor. Which adductor? Adductor longus. On the middle side will be the vastae compartment. Vastae compartment ka middle wala part, which is the vasti medialis. Okay. So the structure which is formed will be between the adductor longus in the middle of the thigh and the vastae medialis, and above the structure is the sartorius. The sartorius is coming from the lateral to the medial side, which is also called as the alti palti वाला muscle. alti palti मार के बैठते हैं ना हम लोग, ठीक है, alti palti वाला muscle, ठीक है. So there is a canal. Now that particular canal is a distal femoral triangle or a adductor canal that we will see, for which we have to go back to our the Chorasiya wala classes, the BD and the BD Chorasiya classes, and we should know the boundaries of the femoral triangle. The femoral triangle, the apex of the femoral triangle is formed by the medial border of the sartorius and the medial border of the adductor longus. And now we have ultrasound with us. So we will see where the medial border of the sartorius and the medial border of the adductor longus muscle will meet. Okay. Yeah. So to my this is the this is the lateral part. This is lateral and this is medial. So this is the medial border of the sartorius. This is sartorius, skin, subcutaneous fascia, and the sartorius muscle. And this is the adductor longus muscle. So we have to come to a place where the medial border of the sartorius will be meeting the medial border of the. थोड़ा जली लगाएंगे please. The medial border of the sartorius is meeting the medial border of the adductor longus muscle. So this is the distal femoral triangle. This is the place of the middle of the conventional landmark guided technique. This is the middle of the place between the ASIS and the patella. This particular triangle is funnel shaped. एक ट्राइंगल फनल सी है, ठीक है. एडक्टर कैनाल इसके 2 से लेके 3 सेंटीमीटर डिस्टल स्टार्ट होता है. अंडरस्टूड. सो वी आर गिविंग इन द नेम ऑफ एडक्टर कैनाल द DFT ब्लॉक. And there is some physiology of the post-operative pain, TKR pain, which is attached to it. Okay, once again, both the middle motor borders will meet. Okay, so here what we are doing, we are giving the drug in which plane? This plane. And what are the contents of the distal femoral triangle? The femoral artery, the vein, and the saphenous nerve. Then the saphenous nerve. And there is one more thing which is present in this, which is the nerve to the vastus medialis, which is an important nerve. We are giving a drug in this particular area, but there is no motor weakness, even though there is a nerve to the vastus medialis. Why? Because the motor components of the nerve to vastus medialis, they have taken off in the proximal femoral triangle only. Okay. Now below this distal femoral triangle, where we can put in a catheter, we have blocked only 2 nerves. One is vastus medialis nerve, the saphenous nerve, and some part of the infrasartorial plexus, sartorius plexus. Okay. When we come distally, in the distal femoral triangle, okay, there is one more membrane which is there, which is called as the vasto-adductor membrane. The membrane which is separating, which is connecting the 2 compartments, the vasti and the adductor. Vasto-adductor membrane. भाई भाई के साथ रहेगा, बहन बहन के साथ रहेगी. अगर नर्व टू वास्टस मीडियालिस है, ऊपर से आ रही है, तो मेम्ब्रेन के ऊपर से जाएगी अपनी मसल के साथ, सेंसरी नर्व. ठीक है. सैफनस नर्व क्या करेगी? मेम्ब्रेन के नीचे चली जाएगी. ठीक है. अगर हम डिस्टल फेमोरल ट्रायंगल के थोड़ा और डिस्टल आ रहे हैं, अंडरस्टूड, नर्व टू वास्टस मीडियालिस ऊपर चली गई और हमने नीचे चली गई. हमने कन्वेंशनल टीचिंग के अंदर क्या करा कि हमने आर्टरी के आसपास ड्रग डिपॉजिट कर दी, पर कौन कौन सी नर्व का स्पेयरिंग हुआ? नर्व टू वास्टस मीडियालिस एज वेल एज द सब सार्टोरियल प्लेक्सस. ओके. अब पर हुआ क्या यहाँ पे, इस पर्टिकुलर पोजीशन पे क्या हुआ? डिस्टल टू इट इज़ ए कॉइल्ड सॉर्ट ऑफ ट्यूबुलर स्ट्रक्चर. ऊपर तो फनल था, ऊपर फनल था, नीचे ट्यूब है बस. ठीक है. अगर हम 20 ml ऑफ ड्रग यहाँ पे डिपॉजिट करेंगे ट्यूब के अंदर, ठीक है, क्या होगा, ड्रग ऊपर भी आ सकती है पर ज़्यादातर ड्रग नीचे की तरफ चली जाएगी, ठीक है। जब नीचे जाएगी तो क्या आएगा, लॉन्गस ख़त्म हो जाएगी, मैग्नस आ जाएगी, फिर मैग्नस के अंदर एक ट्रायंगल सा बना होता है जहाँ से फीमोरल आर्टरी पीछे चली जाती है। एडेक्टर मैग्नस का होता है ना वो ओपनिंग, ठीक है ना, जहाँ से फीमोरल आर्टरी पीछे जाके पॉपुलर आर्टरी बना देती है और यहाँ से हम पॉपुलर आर्टरी देखते हैं, ठीक है। तो टीचिंग क्या कहती है, इफ़ यू डिपॉजिट द ड्रग इन द डिस्टल फीमोरल ट्रायंगल and a large volume of drug, comfortably large, maybe a 20 ml of drug in the thoda niche down in the adductor canal, then you will block the components of the femoral nerve as well as the sacral plexus. So this is called as a dual subsartorial block. You are placing the drug at 2 points, the DFT and the niche wala point. So this is called as the dual subsartorial block. Understood? समझ में आया? कोई डाउट? फिर से नदी ढूंढते हैं. So this is a place where the sartorius muscle and the adductor longus muscle is meeting. Slowly and slowly as we come down, what we will see, the adductor longus muscle will recede. And this is also called as the shark eye appearance. मेरे को तो पता नहीं कभी साइन याद नहीं होते, मतलब practically speaking कौन सा साइन कब आया. पर स्लोली अब क्या हुआ कि एडक्टर लॉन्गस का तो बेली खत्म हो गया और एडक्टर मैग्नस का बेली इज कमिंग अप. ओके, सो दिस इज द ट्रू एडक्टर कैनाल. या दिस इज द ट्रू एडक्टर कैनाल. There are a hell lot of intricacies which is present, anatomical intricacies which are present in this adductor canal, and I think today we have some paucity of time, and tomorrow I will be in that particular station only, and I will show you all other things in the adductor canal, that how adductor canal can be divided into the three parts, the proximal, mid and the distal adductor canal, and what is foreign block, one block, what is caps block, what is pop sciatic block, and everything. And now if we want to do a surgery, some practical tips and some practical questions is, if we want to do a surgery at the level of the tibia, if we want to do a fracture tibia surgery or debridement of the diabetic foot in this below the knee, then what block should be given? Pop sciatic block and saphenous block. Saphenous nerve is a cutaneous nerve or a motor nerve. It's a cutaneous nerve. भगवान ने ना डिवीजन कर दिया है. ऊपर का हिस्सा लंबर प्लेक्सस का, नीचे का हिस्सा सैक्रल प्लेक्सस का प्राइमरीली. सैक्रल प्लेक्सस की थाई के अंदर सिर्फ हैमस्ट्रिंग्स के अंदर थोड़ा बहुत कंपोनेंट है, बाकी सारा का सारा बिलो नी विल बी बाय द बिलो नी इज द सैक्रल प्लेक्सस ओनली. आपने डर्माटोमल डिस्ट्रीब्यूशंस भी देखा होगा ना, L4, 5, S1, S2, S3, सिर्फ सैक्रल प्लेक्सस ही, L1, 2, 3 तो ऊपर ही है ना डर्माटोमल डिस्ट्रीब्यूशंस में. ओके, सो प्राइमरली द ब्लॉक विच इज़ इम्पॉर्टेंट टू डू द बिलो नी सर्जरीज, एनी सर्जरी, बी इट बिलो नी एम्पुटेशंस, इज द पॉप sciatic nerve block plus the saphenous nerve block for giving the cutaneous supply. Now where all the saphenous nerve block can be blocked? Either in the femoral or adductor canal, डिस्टल फीमोरल ट्रायंगल. एडक्टर कैनाल में तो हाँ ठीक है, हाँ वो हाँ वहाँ पे भी हो सकती है, हाँ वहाँ पे भी हो सकती है एडक्टर कैनाल और द DFT. एंड देयर इज़ अ वेरी सिंपल ब्लॉक विच इज़ कॉल्ड एज द saphenous nerve ब्लॉक. उसमें कुछ नहीं करना.
Manish sir, can I just interrupt you for a second?
नहीं sir, you can interrupt me completely.
Sir, this is the last the P-adder resistance as
drug in the subcutaneous plane. And on the middle side of the knee, depth कम कर देना please. Depth कम कर दीजिए. On the middle side of the knee, just look for the vein. थोड़ा बढ़ाना, gain increase करना. So this is the vein. Just deposit the drug on the in a perivenous area in the subcutaneous vein. The saphenous nerve is block. Subcutaneous area में vein को देखो, great saphenous vein, उसके साथ अपना drug deposit. So pop sciatic and the saphenous nerve. And thank you very much. Thank you very much, dear audience.
with this, we conclude the live and master class, and there will be panel discussions on individual blocks. So proceed for the lunch. Thank you.